Good evening, Dr. McGinty. Really appreciate that you gave me the time from your busy schedule, and I know how busy you are usually, and ready here to discuss with us something a little bit different than usual, talking about the relationship between dentistry and medicine, how we can improve it, and all in the goodwill for the general healthcare. So with that, I just want to tell how I met you. I met you as a student, actually, even at this age in my life. And you were very gracious of, putting up with me. And I'm doing that program that people know you are part of the dual MBA, Master's Healthcare Leadership at Cornell. And you have a big part in the healthcare part of it. So I'm very grateful that I have met you. And secondly, just a little bit about you, that people know more about you. You are a radiologist by training. You have done an MBA also about that. And you are a recognized expert in imaging economics, which it's, people don't know about healthcare. That's a very expensive part of the healthcare. Secondly, you had a great private practice career that ended up also in corporate medicine. And from there, you went back to academia and you became Senior Associate Dean of Clinical Affairs at Weill Cornell Medical Center, and which is one of the best in New York. And I had my children, by the way.
Oh, I think I have to interrupt you. I would say the best, but I know we're
yeah. Well, look, I had my children born in it, although I am an NYU grad, so I cannot say more than that. And also, you focused on artificial intelligence a lot, and we had those discussions in class. So with that, having said all of this, so it's thank you for taking the time. And let's start, first of all, a little bit in general. You are an achieved woman. I have two daughters of my own, so I'm very proud to see. Hopefully, they will be inspired by people like you. So, what would you say to the woman in general to be successful in that domain of medicine?
Look, healthcare has a very diverse workforce. It has a workforce that's actually sometimes more diverse than the populations it serves. But when we get into leadership, it starts to look a lot less diverse. And as you know from my class, I had come from a fundamental belief that teams who have diverse perspectives, whether it's diverse political views or lived experiences, those teams are more likely to question each other and have robust discussion, and they make better decisions. So for me, I'm always looking at ways we can make leadership better reflect the communities we serve, make leadership more diverse, and make our decisions more robust. In terms of actually getting into the room of leadership, both you and I have gone down the road of seeking more business education, and I think that's really important. When people ask me, as a physician or other healthcare provider, do I need an MBA? What I say is, of course, you can get some of that education other ways, but for me, what was critically important was learning the language that people in those leadership rooms speak, and not being intimidated by spreadsheets or just business vernacular. And I think, it is said that women suffer more from imposter syndrome than men. I think everybody has imposter syndrome, especially when people around you are speaking a language that you're not familiar with. So I think familiarizing yourself with those tools and the ways in which performance is measured in leadership is critically important for anyone who wants to get into leadership. It's what we know is that professional networks are also critically important, having people who are mentors and sponsors. But the evidence shows that women actually need two types of networks. They need a professional network, but they also need a personal network. People that they can really, ask questions about salary or, go through difficult situations. That's apparently useful for women as well as their professional network. Although again, I think that might be useful for everyone. My own experience is that I've been fortunate to have a series of really generous mentors and especially sponsors, and pretty much all of them have not looked like me. So that's, I think, the other thing I would say is that your mentors, your sponsors, although it's good to have some who mirror your lived experience, especially if you're coming from an underrepresented minority in medicine. But don't expect or don't look for sponsors who always are the same as you, because especially for women, I think having sponsors who are already in leadership can really help open the door.
Absolutely. That's very well said, the end of it. That's beautiful. And the second part that we want to move into, it's more into the business part. Talking about medical corporation, they call them the MSO, and the same thing is happening in dentistry, and we call it DSO, basically. In the DSO world, we were fortunate in dentistry for a long time that we had solo practitioners or family kind of a practice, and they had a good relationship between patients and their dentist, and they became friends over the years and so on and so forth. Unfortunately, with the new grad coming out with a lot of debts, I had few residents when I used to run the program at NYU. They came out with $800,000 in debts. Now combine them with married couple, and one of them was one of my associate, married his wife. Also, she did dental school, so they added to that another 300,000. So that's $1.2 million. So they are not venturing in any more buying practices, building practices. Although this fellow that I talked about, he is a venturist, and he went on his own and built his good empire in New Jersey. I'm proud of him. But in general, this is the problem. We're seeing more, we call them the millennial factor, that they are moving into more corporate. Same in medicine. My niece also went into, she works for NYU, don't hold it against her. So, and at the same time, they don't have this connection with the patients. And we are seeing it increasing in it. And people are sometimes faulting that this is why there's no connection, there's no skin in the game. They don't feel like they belong to something, and that's why that concierge medicine is building up and so on and so forth. So what is your take from somebody who's been a very successful leader in the medical corporation?
Look, it is very difficult to generalize. It's difficult to generalize given the variety of medical practices and the variety of experiences. I think that we do often hear providers complaining about not being able to make a connection with their patients, but some of the things that I hear most often as attributed as being at the root of that, a lot of that has to do with the medical record system, the electronic health record system, and the fact that our complex regulatory environment requires physicians to, tick boxes, make sure they've said certain words, and that, the way in which our reimbursement system is set up for certain providers means that they're forced in many systems to see so many patients that they're never going to catch up with their notes. So they go home and then they start their day all over again at home in, we call it pajama time. So that connection with the patients, to me, seems to be a lot to do with the way in which we pay for healthcare. Now, I think there are systems like Kaiser where people aren't necessarily tasked with the same amount of billing compliance because they're a system that, takes full risk on their patients. And I think there are probably still people there who feel burnt out. But, you mentioned my interest in AI, and, I think we're really excited about what large language models, generative AI can do to perhaps remove some of that barrier from the physician-patient interaction, so that instead of typing the whole time, or even as I've seen, typing with your back to the patient, you can actually touch your patient and hold their hand and look at them in the eye and talk to them. But there's no doubt that, there's no perfect system, but certainly systems where we have corporate entities who need to take profit out for non-healthcare provider shareholders are going to have different views on, what the practice environment should look like.
Yeah. My
own practice was a partnership. I will say that we were very fortunate. I got to practice in my subspecialty. We were also tied into the community. As a breast imager, I got to go to tumor board at the hospital. So my own experience really was of providing very high quality care. But being very aware that we were competing with large health systems. So, you know, the answer was never no. If, you know, one of our breast surgeons called at Friday at 5 o'clock and needed a patient seen, the answer was always yes.
Yes. So that's brings us to the really the biggest problem of what you said, the burning out, the exhaustion from complying. So do you think this is the reason why the physicians and the dentist, or the physician don't even think about, hey, probably we should check if this patient is healthy orally and so on and so forth? What do you think about that?
Look, you know, there are so many pressures on that primary care encounter, aren't they? You know, you've got to tick all of the kind of, we'll call them medical boxes of, did you get this? Does this person need their colonoscopy? What's their depression screen showing you? And because I would say our healthcare system is so fragmented, you know, it's in a way not surprising that they're not thinking about that important connection to oral health, because they're probably not necessarily practicing in an environment where if they see something that needs to be addressed, that they can easily get the patient that care. Mm-hmm. So, you know, again, our healthcare system is so fragmented. Yeah. This is just one of the ways in which we do our patients a disservice.
Well, you know, I actually, matter of fact, not that because she practices in Weill Cornell, I had recently an encounter. I have a location now on 74, and I have 74th Street. So most of the patients go to Weill Cornell, closeness and all of that. So I had a patient, true story, it happened with me last week, so I thought I will use it today. His gums were completely, you know, built up, and I asked him what kind of medication you're taking. So I looked at his meds, and one of them is calcium channel blocker, which is a cause of bulking up the gums, and he has a gum disease already. So I called his primary healthcare, and I spoke with her. She's young, you can tell on the voice, and I was very respectful. I said, you know, he's on calcium channel blocker. Can we, because that causes this. She told me, I didn't know that. So I mean, respectfully, I said, you know, I said, yes, it does, and blah, blah, blah. But when I see that, when I hear that, and we will get later on the other ones, the osteonecrosis of the jaw risk because of these bisphosphonates. Mm-hmm. I don't know, as in, I'm still an educator. I haven't stopped teaching, but I'm still in it. But it frustrates me a bit as a clinician, as a teacher. Where did we do wrong as a society, in the medical, where did we wrong? I asked the dean of UPenn, he said that we diverged the medicine and the dentistry from each other. So I wanted to take your take on what I said. How can we remedy that? Mm-hmm. Is this something that can be fixed? We know about the burnout, but about the fundamentals, basic stuff.
Yeah, I mean, you know, I think, and certainly the specifics of, you know, the way in which dental practice has evolved is outside of my expertise. But, you know, the way that we, again, offer services in such a fragmented way in our fee-for-service system, and the way in which, certainly the way in which we have paid for dental services or failed to cover dental services, I think has contributed to that fragmentation. You know, our health system has not encouraged collaboration, and medicine and dentistry is just one failure there. But you know, you think about the way in which we have realized the importance of behavioral health services, right? That if we give people access to behavioral health services, their overall costs of care go down. But we have, through the way we pay for those behavioral health services, carving them out, heavily discounting them, we have forced a fracture, right? So, you know, I keep going back to, we get the healthcare and the dental care that we've decided we want to pay for.
Well, we're going to get to that, Universal. I'm not going to let you go easy with that. So, moving with this same subject, you know, our population is aging. We've been talking about that. You are originally from Ireland. Same problem in England, the same problem in Europe, everywhere. In America in particular, since we live here. So in 2025, all the baby boomers will be 64 and above. So we are going to have quarter of the population as old, basically. Or the third bracket, let's put it this way. It's better.
Yes, we won't call it old when we get there.
Exactly. So. I want to put the word because I'm not that far. So, you know, with people that aging, we have more problems. Things to happen. You know, especially female, we talked about that. They're gonna have a osteoporosis that's going to increase with age. Even male, we are seeing it. I'm not talking about caused by medication or chemotherapy or any of that. I'm just talking about normal aging. And they are putting them on these big medications. And I just want to explain it to the audience that the medication, the bisphosphonates we're talking about, there's still a big phase, and now we have a new family or drug called Prolia, which is not a bisphosphonate, but is also causing the same thing, treated for osteoporosis or for also breast cancers. And they lead to what we call them osteonecrosis of the jaw. It's really non-secure that we can heal it. That happened in the last decade and a half. There is no prediction for it. Some people think that there is a test, CTX. We tried it at the beginning. Some people still on it, but nothing substantial. So we're going into a turf that we don't know. We can extract a tooth innocently, and then we end up with a big problem. And again, we go back to the same thing. Physicians don't even come to their mind, hey, did you see with your doctor, the dentist, So I don't want to repeat the same thing, but we are having these things. So here we have twofold to it. One is the aging population. They're going to have higher risk of periodontal disease if they didn't have it, or if they have it, it's going to go. We're going to go back to the cost. Who's going to pay for that? So patients are going to be retired, living on a fixed income, yet they're going to have to take care of these comorbidities or prevent them. And it's expensive. It's every 3 months, $295, $300 if they don't have a problem. If you have a problem, it's an additive and so on and so forth. So I know you love Universal. So we're going to get to that now. So twofold for it. One, who's going to help them in long term. And I asked Dr. Brown last 2 weeks ago about it. And now I'm going to ask you from somebody that really is a believer in universal healthcare. So having said that, we have two problems. Communication is going back to the same thing. And secondly is who's going to help this care in the long run?
Yeah. Look, again, I don't consider myself an expert. But what I will say is that it seems to me that we need to think differently about preventive healthcare than about sick care. You know, my husband had open heart surgery this summer and he's doing great. But that is when, you know, all of there's nothing he could have done to prevent it. And you want to have all of the sort of machinery of modern medicine, all the expertise around you. Preventive healthcare, though, to me is a totally different animal. It is, you know, education, exercise, how we, you know, our diet, how we do nutrition policy. It feels to me like we've thrown them all under the umbrella of healthcare, and it seems to me that they are two different things.
Yeah, you know, that is exactly what you're saying. It's I had a patient today that walked in, and I told her I will tell the story of her. She came, she has the fear of dentists, so she's never been with a dentist for over a decade, and you can imagine what happened. She's a little bit overweight. She's in her late 50s, early 60s, smokes, diabetes type 2, and we use them as a risk factors actually for us. So I told her, did you ever have anybody ask you, did you see a dentist? She said, no. It was a clear, but for her, it's adding to her problem. So you're right. It's we're thinking about differently, and we need to think differently. So do you think EHR connection between the dental and the medical will it help at all with these things?
Oof, it's theoretically, yes. I mean, the more we're in one system and our patient's information is in one system, the better. The reality, though, is that our providers have so many alerts. So the question is, how can we make that connection seamlessly without adding an additional burden onto primary care providers? And again, this to me, like when I think of the impact of AI in healthcare, sure, I'm a radiologist. We're the ones that are getting replaced by AI, not anytime soon. But we spend, what is it? Something like 8 to 15%, depending on who you read, of our healthcare dollar on administration. So why aren't we looking at AI to strip out some of those costs and nobody wants anyone to, I certainly don't want anyone to be out of a job, but take those people and then deploy them in what people can do, convincing people, educating people, strip out all of that, the work that we do, fighting denials and doing pre-auths, and have people actually work with patients on education and helping them understand why dental visits, why oral health, why good nutrition are such an important part of their overall health.
So why do you think there is a resistance on the AI, obviously?
Oh, the barriers for AI are multifactorial. Let's start with the fact that, the regulatory and the payment environment's not particularly for the sort of the clinical applications is just not particularly well established. On the administrative side, I think that there are some real trust issues. I think that health systems are sort of struggling to think about which ones they should deploy. And my sense is that a lot of the AI solutions have come in as sort of, here's our one solution for our one problem. And the CIO of a large health system is dealing with cyber attacks and, keeping everything running. I think as we see some of these smaller companies aggregate into platform companies, we'll see more momentum. When you can go to one company and get 10 solutions, as opposed to having to negotiate a contract with one little company and let that company into your environment, worry about security. So I think that's been a barrier. Yeah.
So you love AI. I've seen you in the class last time.
So ethical, safe, and useful AI. I love.
Yeah. No, absolutely. So what do you think we would benefit as healthcare providers? Let's call it oral health or health. Where would you think we can benefit from it to the benefit of the patients?
Sure. I mean, there are many examples. Look, I think there's a huge possibility on the sort of clinical diagnostic side. So, I'm a breast imager. So a large part of what I do is screening mammography. It's pattern recognition. It's digital data. So it seems to me that that should be a place where in the relatively near future, an algorithm, and honestly, there was a big study in Sweden that showed that the algorithm did perform well as a second reader. And that's useful not only, we have a workforce shortage in radiology, so it's useful here, but there are many countries who don't even have breast screening programs and are never going to have them because they're never going to have enough radiologists. So that, I think, the ability to expand preventive screening in countries that just don't have the human capital is really exciting to me. And look, expanding those screening programs gives more economic productivity and helps countries grow. On the administrative side, so many, theoretically, the ability to help patients, find a provider that's closer to home, alerts to patients, giving patients information in the language and the format that they find most useful. There are trust issues. Those trust issues are real. And a lot of them, in my mind, come down to the fact that the teams that are developing these algorithms and the companies that are for whom those teams work just don't have enough representation from the communities that their algorithms are impacting. So diversity of leadership, I keep coming back to it. It's important everywhere.
Well, actually, a good fact that I wanted to mention to you, that when I was preparing a paper with Dr. Brown, we noticed that in the rural part of United States, I mean, it's mind-boggling when you see that. If it happens in America, so you can imagine in other countries. the presence of a dentist or a physician, it is so scarce versus a metropolitan.
Mhm.
And you touched on something. So, we talked about telehealth. You remember we talked a lot about telehealth, and what was, for me, it doesn't work in dentistry. Teledental does not work because how are you going to do that? So it doesn't work. But nevertheless, we've used it with consultations. We come, we gather the data, we then, instead of bringing them back again, we do Zoom with them, and that's helpful. But in telehealth, unfortunately, the government stopped paying a lot or made a lot of blockage on it. But that's not helping the rural places. So when we talk about AI, do you think that the AI is also can be helpful for that kind of disparity or that lack of service?
I would never want to say that a level of care that wouldn't be acceptable for me and my family would be something I would tell someone in a rural area that they should accept. But with a workforce shortage that's everywhere for radiology, I would say that as long as the algorithm has been proved to be safe and effective and without bias, then I would absolutely want to employ that. I think that, some of the issues around telehealth regulation are interesting because, yes, there have been government Medicare mostly, which is sort of the template for payment policy. So Medicare until the pandemic was very strict on where it would pay for telehealth. Medicare has become a little bit more flexible since the pandemic, but now we're bumping up against the fact that, as physicians and dentists, we have to be licensed in every state in which we practice.
Correct.
Those licensure regulations are something that physicians have wanted. The Medical Society of New York is vehemently opposed to expanding the ability for non-New York state licensed providers to practice in New York. But we're finding that that's a double-edged sword now, because now we've got patients who've moved to Florida or New Jersey or Pennsylvania, and we want to take care of them, and there are burdensome license requirements. So this is one where our regulatory environment is evolving, and I suspect we'll see some changes because our patients are now saying, why do I have to, as you say, why do I have to come and see you for a follow-up? Why do I have to drive my car into New York City? Yeah.
And it's actually, I learned it this summer with when one of the lawyers that loves you a lot, Cohen, and he's been very inspiring actually in that and that thing. So that's all that what we talked about it. And then we go back to the education in southern United States. We have a huge presence of periodontal disease. Obviously, it's contributing for everything, poverty, education, and all of that. And again, probably, like you said, AI can be a help for the government actually to fill in the gaps that we are not able to fill. So that's great.
Lot to do there in terms of regulation, though, and again, protecting our patients, making sure that we don't perpetrate some of the biases that we know are already in healthcare.
Do you think the AI will be able to eliminate that? If we have a good intention actually in doing.
I hope so. I truly hope so. I mean, there are a lot of people working on this, and as you know, the Biden administration just came out with some new regulatory language. Yeah, I think until we really, make the developers understand the importance of what we do, and that we have physicians and dentists and other healthcare providers in the room with those developers, and again, the diversity of perspective, I think I have to hope that we'll get there.
So I want to end with one thing that I know it's very important to you, talking about diversity. So I am with you on that. And there was a study that came out that said that in JAMA, actually this year, that a Black patient will do better with a Black doctor. Their survivability, their rate of living is much higher if they've been treated with their own race, basically. There's twofold to that. One is the lack of let's say African Americans in the medicine, in the dental. I witnessed it when I was trying to recruit students. I had only one out of my 200 that I trained that was African American, and he's like my young brother. I see him all the time, and I try to help him. So, how can we improve, first of all, the recruitment of the different color spectrum of us as a human being? And secondly, isn't it a little bit against all what we talk about becoming a colorblind if a patient do better with somebody of their own? So how would you answer that for me, please?
There's a lot in there, Edgar.
Yeah.
And obviously, just going back to even the fact that race is really a social construct. And yes, there is data that patients who are cared for by someone who shares their lived experience can have better outcomes. And we know that for some communities, their lack of trust in the medical system is well-founded, right? The book Medical Apartheid by Harriet Washington, it's a tough read, but it's worth reading. But let's focus on how do we make our medical and dental and other healthcare professions look more like the communities we serve. There's a lot of evidence that shows that we have to reach into high school, middle school, and make sure that we're exposing all students to what is possible in terms of careers, and setting expectations, and then providing the educational resources to make it possible. I am so proud at Weill Cornell of the debt-free program that we have. You mentioned debt, and there's no doubt that embarking on an education like that, even if you have a scholarship, if you're coming from a family where you're the first in your family to go to college, and you're potentially having to try and support your family as well, it really makes medical school or dental school much, much more challenging. So what's great about our debt-free program is that if you qualify, you come out with no debt, and that covers not just your tuition, but it covers your living expenses, covers your books, covers the tutoring for all those exams you have to do along the way. So we have to think about programs like that are expansive about what it means to actually, get through all these hurdles. And we also then have to make our spaces welcoming. And I love that story of Justice Ketanji Brown Jackson, who was confirmed as the 9th Supreme Court Justice this summer. And she talked about walking through Harvard Yard and meeting one of the housekeeping staff who just said, persevere. Because I certainly, as a privileged white woman, don't know what it means to walk into a space where I'm the only one. I will say I'm often the only woman in the room, but yeah, but where I'm the only one, and all the pictures on the wall are of people who don't look like me, people who, come from a medical system where I wouldn't have been welcome. So to me, it's incumbent on all of us, whether it's to think about patient outcomes, whether it's to think about leadership that makes better decisions. For me, it's an imperative.
Indeed. Well, I really want to thank you for giving me the time. I really appreciate it. It was wonderful to talk to you and to see you again. And I wish you great holidays if I don't get to see you. And till the next time.
Thank you. And thank you for making this connection. It's something that candidly has not been top of mind for me. And realizing the important impact that oral health has. I'm really glad to have gotten to know you in class and to have made that connection.
Thank you. And all the best to your husband. Thank you.
Thank you.
Bye-bye.